Hello, it's Pieter Gouws, Medical Director from Andean Medical Mission and co-founder of the charity, coming to you from the Beni, which is in the Amazon basin in Bolivia. We've had a week of screening and treating patients across 3 villages to where we are today, and we're taking a moment to pause and reflect on what we've seen and potential problems and solutions for different diseases that we've come across. A striking feature for me was when we went to the first town, which is quite a large town called Riberalta. The advertising for our campaign was to specifically see patients with glaucoma. And when we arrived on day 1, there were over 200 patients waiting, and despite making announcements to say that we're only really want to see glaucoma patients, none of the patients stood up to move away. And when we started working our way through the patients, it became really apparent that glaucoma was just the tip of the iceberg that we were seeing. There were many blind patients who were just desperate for a diagnosis and a possible chance of vision. We did see a lot of glaucoma patients, and unfortunately a lot of blind patients from glaucoma, but there was also a significant amount of patients who were blind or nearly blind from cataract. And we had a good smattering of lots and lots of different pathology. To give you an example, we had patients coming in with fresh or old retinal detachments. We had 2 patients who were losing vision from retinitis pigmentosa. We had quite a smattering of young people, and the most striking one was a lovely girl who had a very obvious ophthalmos from congenital glaucoma in one eye with no vision in that eye, poor vision in the other eye, and had really never been given any appropriate treatment for her glaucoma at a young age. A pretty simple operation would have kept her vision and given her a normal appearance, and she really was just interested in something that would get rid of a large deformed eye to make a cosmetic difference for her. We saw lots of kids who had lost vision in one eye from intrauterine infections. So there's still really work to be done here with looking at antenatal programs and screening for infections. Striking one that comes to mind was a mum that brought her 3-year-old son because he had an alternating squint, a deviation of the eyes. She was really worried, and it became apparent why she was worried when she asked her 14-year-old son to come in, who had a very marked squint and unfortunately had lost most of the vision in his eyes due to congenital toxoplasmosis. Mum was diagnosed only when they realized when he was a baby that he had very poor vision, and the ophthalmologist looked in his eyes and said, oh yes, he has toxoplasmosis. The mother and her son were then treated, but unfortunately too late to save his vision. And understandably, the mother was very concerned about her younger son now also having a squint. The good news for him was he had completely normal vision in both eyes, and it was a reassuring role. But it just gives you a really good idea of the vast range of diseases that we see. And the biggest feature really in all of them is that the desperate need for number 1, a diagnosis, and number 2, possible treatment. The other thing that was really striking to me was patients who'd been given a diagnosis of glaucoma, and some of them many years before, and almost universally when we asked them about their treatment, they'd all been told which drops they should take, but the glaucoma drops in Bolivia are that expensive that they have to make a choice between putting drops in their eye or buying food in many instances, and the drops therefore go in very sporadically, and as a result these patients are losing vision. And there was quite a significant amount of patients who were blind in one eye with very little vision remaining in the other eye from end-stage glaucoma. This is something that as a charity we need to take forward and David and I have had a long discussion and have decided this would be one of the future directions for Andean Medical Mission, to see what we can do to actually become a distributor of affordable drugs in the UK for in Bolivia for our patients that we see with glaucoma, and the obvious thing is to have a named patient base where we can supply them with their monthly drops to ensure that they, number one, are getting the treatment and that it's affordable. So we would provide it to them at cost. It was a great pleasure to introduce our first YAG laser to the country. So a noticeable event for me was a patient that I'd operated on in 2019 who was blind in one eye, and the eye that I'd operated on was still seeing well, but he was noticing that the vision was getting a bit cloudy. On examination, he had posterior capsular opacification, which I very quickly treated with a YAG laser capsulotomy, and we had a very happy patient who insisted on having a photograph with us all together. There are many little success stories like this. We saw many patients that we'd operated on over the years, and unfortunately we also saw many patients who'd had surgery elsewhere and had lost vision completely in those eyes from complications. And 4 of the patients who'd had failed previous surgery for cataract in one eye had gone on to develop blindness in their fellow eye because they were obviously too scared to have surgery on the fellow eye, developed hypermature cataracts, which led to inflammation and high pressure in the eye, and they now have blind eyes with no hope of any future vision. So there really is a lot of work to be done with education and to try and get to patients earlier so that they have a good outcome and therefore aren't reticent to have surgery to the fellow eye, so we don't end up with patients bilaterally blind from avoidable disease. It's really fantastic to see that since our beginnings in 2011, when we established the charity with our first trip in 2012, we've built a really solid reputation in the Beni, and everywhere we go, patients really trust us and trust our opinions. And I can give you a great example of a patient that we saw in Riberalta. We saw a gentleman who had an eye problem which was relatively trivial. With education, he was extremely happy and went off, and our next trip was 7 hours down the line. The next day he appeared with his daughter, having driven 7 hours down the road to find us, and his daughter had been to one of the bigger cities with a headache. She'd had a MRI brain scan, and she was told that there is a tumour in her pituitary gland and she would need emergency surgery, otherwise she would go bilaterally blind. We have seen in the few years that I've been looking at patients here, 5 completely bilaterally blind patients from surgery for pituitary masses. Fortunately, she'd taken a screenshot of her scan, and it was very apparent that she had a cyst that was only very slightly displacing the optic nerve or the optic chiasm. I was therefore able to reassure her that the much more prudent course of action would be to have a repeat scan after 3 to 6 months and again a year later, because if the cystic lesion shows no sign of changing, it would save her the possibility of blindness from surgery. And in a 37-year-old lady with 2 young children, I think that's a very important consideration. And it just links into the amount of trust and confidence that patients have in us as an organization in Bolivia. In the last village we were at, San Borja, we spent a day with one of the local ophthalmologists who we have nurtured along with our trips over the years, and it was really great to get Fernando to show us patients that he was struggling with and to spend a whole day with intensive teaching whilst looking at the patients, ensuring that the patients have good outcomes. He felt that he had learnt a lot, and that he would be a lot safer and more confident in managing patients with similar conditions going forward. And that is the kind of training that we try to achieve as we go across the country in various bits. Quite often, unfortunately, local ophthalmologists are reticent to engage with us, and will make promises of attending teaching sessions and never appear. But we will strive to continue to provide training not just to eye doctors, but to every primary care practitioner, as we have been doing, as there is a great need for early intervention for simple conditions like corneal ulcers that are blinding in people because they haven't been appropriately managed. David makes a point, and we did that again on 2 occasions during this trip, of stopping over at small villages and ensuring that their eye drop stock is up to date and stocked up, and they all know that they can contact him directly for a telemedicine option. And if he can't supply them with adequate advice, he will contact me or one of our core group of consultants in the UK for a pretty speedy answer to give appropriate treatment for those patients. Another feature that we saw repeatedly was patients appearing in some cases with a large bag of various drops that they'd been given over the preceding year or 2 for eye conditions. And to give you a simple example, we saw a patient with blepharitis, which is an irritating, annoying lid condition, which is very easily manageable. She had had every antibiotic treatment as well as steroid drops available, including some really quite potent drugs like vancomycin and gentamicin in drop form, obviously with no relief of her symptoms. And that has been a feature in many of the patients we saw, where the person seeing the patient doesn't have the appropriate skill or knowledge to decide what the diagnosis is, and just does a blunderbuss of treatment with every drop available. So we've seen lots of patients on glaucoma drops for a supposed diagnosis of glaucoma. When we asked them to stop the drops and reviewed them again, based on the fact that the optic nerves were completely healthy, the pressures were completely normal, and drops are really expensive in Bolivia. So not only are patients putting in unnecessary treatment, this is a huge financial drain on patients for an unnecessary treatment. Going forward over the next 5 years, Andean Medical Mission will continue to do camps as we're currently doing, as we've now reached 2,000 cataract operations in the Amazon basin. We continue to find new young consultants who are very keen to become involved, and have had great success stories with people very quickly adapting to the very difficult conditions. It's very different operating on a patient with bare perception of light and a black cataract compared to the cataracts that you might do with modern phacoemulsification in the UK or other parts of the world. And there is a steep learning curve. We have a core of very experienced surgeons who help to train or guide consultant ophthalmologists who are new to this kind of treatment, but who are in themselves very experienced surgeons, because it's a big step away from being an experienced surgeon in a first world ophthalmology setting to having to deal with the pathology that we see during surgeries in Bolivia. And there are definite adjustments that need to be made to surgical techniques, etc., to ensure that we get excellent results. The focus over the next 5 years for AM as an organisation will be to build and expand a glaucoma service. The next step would be to get a base where we can have a selective laser trabeculoplasty as well as subthreshold cyclodiode available to treat patients, as that would massively reduce the drop burden. In addition to providing laser treatment for glaucoma, obviously, as I mentioned earlier, we are going to explore becoming an importer of generic glaucoma drugs that we can supply on a named patient basis to make glaucoma treatment affordable for all of our patients who have glaucoma. So in 5 years' time, I'd like to see Andean Medical Mission with an established treatment base in the Beni, where we can arrange for patients to be transported to and from for laser treatments, as the machines are quite delicate, and transporting them into rural areas often leads to the equipment malfunctioning, as we discovered on this journey, unfortunately. The idea would be to have an associated theatre space as well, where we could be doing surgeries, and of course we will continue the excellent work we are doing on building our good name and treating blinding, pterygia and cataracts across the Beni. Due to an increasing amount of oculoplastic surgeons joining our group, we've also now expanded our services to removing obvious tumours on the face, the most common being basal cell carcinomas, with some squamous cell carcinomas as well. And this has been very well received by the patients that we've treated.